Welcome, everyone. We'll just wait a minute or two for all the Zooms to connect. So, welcome to this webinar of the Global Observatory of Long-Term Care. I'm Adelina Comas Herrera from the London School of Economics, and together with NAS, we run the Global Observatory of Long-Term Care. It is our pleasure to have this webinar today, which is from the Quality Improvement Interest Group. And I'll very briefly introduce the observatory in case you're new to it, and we'll let you know also about our next webinars. So the Global Observatory of Long-Term Care is a platform to support cross-national learning on long-term care. Our aim is to support the strengthening of care systems. It's part of the International Long-Term Care Policy Network. And we are looking to identify shared challenges and showcase how different countries and localities are addressing them. And we basically share research evidence, but also country experiences, local experiences, and facilitate collaborations. The observatory is open to everyone. You can become a member, and then once you're a member, you can join any interest group you'd like. And you can also contact us if you'd like to share your publications, contribute to long-term care system profiles, blogs, and writing methods and topic guides. We're gradually developing quite a large database of experts. We already have 660 experts on long-term care listed by country, topics, and methods. If you're not in it and you'd like to, please use the link that we will share in the chat. And we also now have a really fantastic library of videos of the previous webinars. We have an event on the 28th of November on changing the narrative on long-term care. It's a whole day event. It starts really early in the morning for those of us in Europe, in Australia, and it will end in Chile in the evening. And during the middle of the day, we will have presentations hosted from here, from LSE, from Europe. And I'd like to say that I can just announce that the Minister of the Minister of Senior Citizens of Denmark will be joining us and will be presenting the new reforms in Denmark. And to tell you a bit more about the next webinars, the next one will be on the 24th of November, which is on innovation in long-term care. We'll have obviously this event of the 28th of November on changing the narrative on long-term care. 1st of December is a webinar of the economics of long-term care interest group, looking at evaluating long-term care around the world. 10th of December, it's more methodological, looking at the use of AI in qualitative research. And 14th of January, we will have a webinar on the impacts of changes in migration politics on the social care workforce. 2nd of February, sustainable continence care in long-term care, and 5th of March, joint pain in long-term care and qualitative methods. So you can see we have a very diverse program. I hope you will be considering to join us for some of those, and also, of course, the future webinars of the Quality Improvement Interest Group. So handing over to Cassandra and Belis, who's going to tell, who's going to tell us about this interest group.
Yes, thank you, Adelina. My name is Belis van den Berg. I work at Filans, the Dutch Center of Expertise for Long-Term Care and Support. And together with other colleagues of Filans and WHO, I organized this special interest group on quality improvement in long-term care. And we aim to facilitate discussion and exchange on this topic. And this is our 3rd webinar. We had 2 before, and the records of these webinars are indeed available at the website of the Global Observatory. Last webinar was, for example, about making quality visible. Very interesting topic. So I recommend to have a look at this record. And if you have any interesting articles or other publications to share, please send these to us so we can put it on the repository of the website. And next year we will also organize other webinars. So if you have any ideas about topics or interesting approaches to improve quality in long-term care, please let us know. This can be about learning culture or using data or other country approaches. So please let us know. I will put my email address and the web link to the webpage of the Global Observatory in the chat. And now we have a deep dive in the French experiences. So I will hand over to Cassandra to introduce the webinar of today.
Great, thank you very much, Bellis, and thank you everyone from my side also for joining today, what I think is going to be a very interesting webinar. So as Bellis was talking about the quality improvement group here at the Global Observatory, we're very much interested in learning about different experiences of quality management across countries. You know, how is quality management structured? What efforts are taking place across countries to improve quality of long-term care? What are some of the challenges and how are countries overcoming these? So I'm very pleased today to be introducing Angelique Khaled, who is the Director of Quality of Social and Medical Social Support at the, I'm not going to say the French name, at the Haute Autorité for Health. She's been Director of this department since 2023. And the Haute Autorité de Sante is the national authority that's overseeing quality in health, social and medical social care. And they've been really shaping how nursing homes, how home care organizations and hospitals are being evaluated on quality. They have a 2025 to 2030 strategy, which places a lot of emphasis on ensuring that quality follows each person throughout their care journey, and which stresses also including the voices of residents and families in the process. So today, Angelique will be talking about the French experience of quality management, including the new evaluation framework that they've developed and have started implementing. And she'll talk about what the process was like for developing this framework. And I know that she has some quite recent results of this process, which will be very interesting to hear about. And once she's done presenting, we'll have then some time for questions and for a discussion. So please take note of your questions and wait for those until the end. Now, without further ado, I will pass the floor to you, Angelique, to present.
Yes, good morning, everyone. Do you hear me well?
Yes, okay. We do.
Thank you very much, Cassandra. I'm very pleased to be here with you for this webinar about quality in long-term care services in France. So, as Cassandra told you, my name is Angelique Khaled. I'm the Director of the Quality of Social Care Services in the HAS. And in this presentation this morning, I'm going to talk about the new single uniform evaluation framework for all social and medico-social institutions and services in France, which is based on the quality guidelines largely common to all social structures. So it is implemented in long-term care services in France, but also in other types of institutions for the institutions for the disabled people, for example. It is also implemented in the institutions that care about protected children, and also institutions for the homeless people. So it is a largely common quality framework. We can go on to the second slide. Thank you very much, Nas, for the slides, because I haven't achieved to do it myself. Thank you. I will, before coming to the main point, I will tell you just in some quick points, a few words about the HAS, because it is quite specific in the French system. So the French National Authority for Health, it's an independent scientific advisory body. So we are not controlled by the states, by the French government. It is an independent body. And our main purpose is improving quality both in the health system and in the social services. So we have a broad area of action, healthcare and social care services. We can go on. So in the HIS, we have 3 core missions: assess and appraise pharmaceuticals, devices and procedures for inclusion on the national list of reimbursed products and services. The second mission is to recommend best practices. So in my directorate, we elaborate guidelines for the professionals who work in the social care services and institutions. And the third mission, it is the mission I will talk to you, I will talk about it to you. It's measure and improve the quality of care delivered in health and social care organizations. But as you have understood, I think, my directorate is only responsible for social care organizations. So to begin with our topic of the day, we can go on to the next slide. Just a word about what is evaluation in France. I don't see the next slide, but I go on. The obligation to carry out an evaluation for the social sector has been enshrined in French law since 2002, but it has been amended considerably by a law passed in 2019, and it is with that law that HIS has been put in charge of this evaluation. This law stipulates that the 45,000 social care services and institutions that provide support for people in the 4 sectors that you see on the slide must receive an evaluation visit every 5 years by a team of external evaluator certified by the HIS. The evaluators must conduct the assessment using the quality reference framework that I will present to you in a moment. And it is a big new thing this year. The results of the assessment must be made public now. So on the next slide, I will give you some key figures about elderly care in France. So we talk about 2024. We have 18.9 million people aged over 60 in France. This represents more than a quarter of the population. And you see there the population projections by INSEE that forecast a big increase of the number of people over 60. According to the central projection scenario, there will be 22.6 million people over 60 in 2045 and 23.8 million in 2070. So their share of the total population will increase from 28% in 2024 to 35% in 2060. This is for the demographic trend. The table on the left shows you the distribution of elderly care facilities and their capacity in France in 2023. You see that nursing homes dominate the sector with more than 600,000 places. So nursing homes represent about 81% of all installed places. And you see that we have many places providing by the for-profit sector. The private sector accounts for roughly 18% of the total capacity. The public sector remains the largest contributor with nearly 300,000 places, while private non-profit organizations, so held by associations, provide around 180,000 places. Next to the nursing homes, we have independent living residences. In those residences, there are not medical staff. So the independent living residences represent 100,000 places. So overall, the French system comprises more than 10,000 facilities offering 756,000 places, and nearly 20% of which belong to the private for-profit sector. This diversity makes evaluation all the more essential to ensure consistent and homogeneous quality. On the next slide, I will talk you about the main aim of the quality assessment. Of course, it's to offer the best personalized support to the people, support that must be adapted to the needs and expectations of each individual. The objective enshrined in the law is to provide the authorities with quality guidelines for examining the renewal of the authorization of social services, but of course, the reasons for carrying out a quality assessment are much broader and more essential. It allows the users to be informed on the quality level of the structures supporting them or that will support them in the future. But it is also a very important tool for professionals in terms of management and improving practices. At the very beginning of our work to develop this quality framework, the first step was to identify the issues at stake. 3 major issues were identified by the HIS governance. The first is enabling people to play an active role in their own pathway. The second is strengthening the quality approach in social care services. And the third is to promoting a meaningful approach for professionals. We can go on with the next slide. On this slide, I would like to show you the steps in the project that led to the National Quality Framework. It has took great time. The law you see at the beginning, the law entrusting the HIS with the mission was published in July 2019. And from September 2019, working groups were set up following a call for applications. These working groups were made up of service providers, professionals, and also users. Users are fully considered as experts in the HIS for all our works. We decided to set up 9 working groups, each responsible for a specific theme. The 9 themes of the framework are listed in the following slides. Each working group met 4 times with 2 plenary meetings. So it took 1 year to produce a first version of the framework. And this first version of the framework was put out to public consultation. You see at the beginning of the year 2021, we received almost 9,000 contributions, all of which were analyzed by the project team and that led to changes in the framework, particularly in the terms used. It was refined by the working group at a 5th meeting, so you see it at the mid of 2021. The project team then spent 2 months on the field to experiment, to test the framework in each type of social care services. And during those visits, they tested the criteria and the investigation methods with professionals and users, which led to further changes in the framework. And it was finally adopted and published in March 2022. So it took more than 2 years to end it. On the next slide, it is a quick slide. It is to tell you about the 4 key principles that underline the framework. Initial instructions given to the working groups by the HAS were to draw up a set of guidelines centered on the individual and based on those 4 fundamental values. So self-determination, respect of the fundamental rights, inclusive approach to support, and ethical knowledge of professionals. But I will give you more details about the framework, about its structure in the next slide. So the assessment framework is structured into 3 chapters, 9 themes. You can see the 9 themes on the slide, 42 objectives and 157 criteria. The choice of structuring the framework in 3 chapters is a direct response to one of the strategic orientations that was set from the beginning. It is to develop a 3-level quality framework, with chapter 1 focusing on the individual, on the accompanied people, the chapter 2 focusing on professionals, and the chapter 3 focusing on service providers. The 9 themes make it possible to review all the issues that will determine the quality of support in social care services. Most of them are common to the 3 chapters, and some are specific, including 2 themes that are specific to chapter 3, because they will be addressed in the interview with the organization's governance. So on the next slide, it's an example of how the active involvement and participation of the user's theme is broken down in chapter 1 of the framework. To achieve this goal, we have an objective. The person's expression is collected throughout the support process, and then we will break the objective into 3 criteria that you can see on the slide. So the quality framework therefore contains 157 criteria. We can go on the next slide. The vast majority of these criteria are told general criteria. They apply to all types of services, whatever their organization and whatever the public they serve. And among those 157 criteria, only 28 are referred to as specific. They do not apply to all facilities, but it depends on the sector, the type of facility, or the public served. I go on the next slide with the presentation of the criteria. Among those 157 criteria, some of them are called standard criteria. They have been defined to show the expected level, and 18 are called imperatives criteria. Those 18 imperative criteria must be entirely fulfilled. They mainly relate to users' rights, but also to managing the risk of abuse, violence, complaints, and claims. We chose to highlight those 18 imperative criteria as the first minimal level of quality that every social care services have to reach during the first evaluation exercise. So these 18 criteria are analyzed in a separate section of the assessment report. And if they are not fully satisfied, the social service have to prioritize them in the action plan it will undertake following the assessment. Each of the 157 criteria is described in detail in an evaluation guide. It contains all the elements needed to assess how the criteria have been implemented in the social service. In the guide, for each criteria, we can also find legal references and professional practices guidelines made by HIS. On the next slide, a word about the scoring system. All of the interviews and answers provided during the visit, as well as additional explorations, must be used to score the assessment elements. The scoring system is based on 5 levels, one being the lowest level, and the star, the asterisk, it is the highest level because it allows us to value a great professional practice, an outcome that goes beyond what is expected. The evaluator does not rate the criterion, but he rates each element of assessment that makes up the criterion, and then we have an evaluation software information system that calculates a successive average to give a score for the criterion, and then a score for the objective, and then a score for each of the 9 themes, and a score for the chapter. On the next slide, about the report, after the assessment visit, the evaluator draws up an assessment report and sends it to the service. This report must also be sent to the authorities, regulatory authorities, and also to the HAS. So why the HAS? Thanks to this report sendings, we can check the conformity of the work of the evaluators' bodies, which must follow our methods and use our tools. So that's the first reason. But the second reason is even more important. By receiving all the assessment reports, we can analyze the level of quality achieved by the social care services. In fact, our information system can produce an overall score for each structure, which can be seen in the diagram you have before you. And this will enable us to inform the government authorities, but also to include themes in our work program for producing guidelines for professionals to support social services so that they can improve the areas where they had some difficulties. On the next slide, I show you some results focused on the long-term care sector. So these results have been made at the end of 2024. So it represents 2 years of implementation. More than 3,600 facilities and services for elderly people have been evaluated during those 2 first years of implementations. So we have 32% of the total of nursing homes that have been evaluated, 23% of the total of independent living residences, and 6% of the total of home care services, because there have been a delay for the home care services because we have currently a reform of those services. So the national authorities, the ministry have delayed the assessment for those home care services until the July of 2025. It explains why there are not so many that have been evaluated yet. So here are the key data. So I remind you that the rating is based on 4. We see by thanks to the analysis of the results that institutions are experiencing some difficulties with topics related to formalizing the procedures and tools needed to structure their activities. You see very poor grades on quality policy and risk management. On the other hand, they achieve very good results in terms of respect for human rights and participation of the users. Those 2 topics are the 2 top grades. I have highlighted the results for nursing homes because they appear to be performing relatively better in the assessment. This can be explained also by the general inspection plan carried out by the state authorities in all nursing homes in France in 2023 and 2024, following the scandal of a major quality deficit in the establishments of a private group that occurred in 2022. So a general inspection plan had been implemented, and nursing homes have worked on their procedures for that. So they have better grades in quality policy and risk management, for example. So I will now talk about the publication. on the next slide. It is my last part of the presentation. I would like to mention these major advances in the national evaluation system in France this year. Since the 15th September of this year, we published the evaluation results of each structure, each service on the HRS website in a space called Caliscope, which contains, as you see, the rating of each of the 9 themes, the number of imperative criteria achieved, the social service global score, a 4-letter quality scale with A, B, C, D, like the Nutri-Score, and an extract from the assessment report. Just a few words about the quality scale, and especially how it is calculated. So the quality scale is calculated using a formula that takes the average of the scores obtained on the one hand, and on the other hand, the rate of achievement of the imperative criteria. We have chosen to develop a 2-dimensional scale because we have considered that a single dimension could mask the strength, could hide the strengths and weaknesses of a service. For example, a good overall average could hide the fact that many criteria classified as imperative had not been met, had not been achieved. On the contrary, some institutions may choose to focus on the imperative criteria without initiating a general dynamic. So that's the reason why we have built this 2-dimensional scale. This publication is an important turning point for the actors, for the players in the sector and the assessors. And the decision to publish these results meets the general public's expectation of transparency and information. Even though several consultations, meetings were held with stakeholders, we received strong reactions after publications, especially from the for-profit private sector. On the next slide, in addition to publishing the results on the website, the social care services will also have to display them on their premises, which is now an obligation. You can see the you will see the poster on the next slide. This decision was taken again for reasons of transparency, but also to encourage discussion between accompanied people, their families, and the teams of professionals about the quality approach implemented by the establishment to improve the support provided. And then my last slide, it's about our thoughts for the next evaluation cycle. It will soon begin. It's in 2028, but we have to be ready before that. We are currently starting to work on this second 5 years cycle. So in this slide, I want to propose you the levers we have and the areas for improvement that we have identified to strengthen the evaluation process. The levers is that we have a national framework. So every service and every institutions, wherever they are on the territory, they are assessed in the same way, on the same basis. We have tools to promote the quality approach. We have a person-centered framework that is very important to start with the person expression about their needs and expectations. We have quality control of reports made by my staff in the HRS. We try to control more and more reports to see if the assessors are doing good work. We have annual meetings with their coordinators. SMS is the assessment bodies coordinators. So we have annual meetings with them to give them our expectations. And we have a partnership work with COFRAC. COFRAC is the National Institution of Accreditation. So it is the COFRAC that gives the permission, that allows assessment bodies to work. So that these are the levels and the areas for improvement. At the same time, we think that we will have to work on considering more some sector-specific characteristics. There are some sectors, especially in the social fields, in the housing field, that have some difficulties with the framework. We see also that we have market concentration of evaluation bodies. So we are trying to fix some difficulties with this market concentration. We have some complexity of the accreditation process. We have to strengthen adoption of the framework by providers. They need time to adopt it. We have to strengthen the evaluators' qualification level, because as the framework is common to all sectors, that means that the assessors must have some skills to assess every type of service and institutions. And we have some we have to secure enough evaluators to carry out all evaluations, 45,000 evaluations in a 5 years cycle. It's a lot of evaluation to do. So we have to secure the number of assessors. To move forward concretely on this next evaluation cycle, we will set up working groups to co-design solutions with stakeholders. We will also launch a survey among institutions to gather feedbacks and expectations. Those contributions will be very precious, essential to adjust our tools and make evaluation truly useful for team in their daily work. Our main objective remains to convince them to no longer consider assessment as an administrative constraint, but as a real opportunity for improving their practices and support for users. So I've reached the end of my presentation. Thank you very much for your attention.
Thank you so much, Angelique, for this presentation. I know I had already heard you speak before about the work that HAS does and the development of the evaluation framework, but still hearing even more details and hearing about the results over the last months after they were published has been really interesting. And I personally have many questions, and I see already we've had some questions in the chat, as well as we've got some hands being put up. I just want to, if I can just say, we had a few more housekeeping questions in the chat. I'll just address those quickly before we open the discussion. Michelle has asked if we can if they can get the PowerPoint later. I know that the recording will be published online on the GOLTC website. I'm not sure if we share the PowerPoint too. Adelina?
If Angelique is, if you'd like to share it, then we will include it in the post that has the video, or we can also have a version of the PowerPoint, Angelique.
Yes, there is no problems to share the PowerPoint.
Thank you.
Okay.
Great, thank you, Angelique. Kathleen has also asked Angelique if there is a website link where the publication of the results is done. I think we're all very interested to take a look to see how this looks across providers and what the different results look like. So if you could share at the end or at some point, it would be fantastic.
Okay.
Thank you.
I will put it in the chat.
That's great. Thank you very much, Angelique. I'm going to abuse my power as moderator and actually push my first question in, because I'm really itching to hear, and then we'll start going through the questions from all participants. I was really fascinated to hear about the results. You mentioned once the results were published online that there were quite strong reactions from the for-profit private providers. And I guess this isn't unexpected. This is something we probably would anticipate in such a situation. I'm wondering if you can speak a bit more about that, and also talk about what steps do you think need to be taken to build better alignment with the private sector around the goals of quality. Of course, private providers have their own motivations, their own incentives, but how do we bring alignment, and how do we show private providers or help them to see the process as fair and transparent and beneficial, rather than, punitive or something against them?
Yes, you're right. It's true that in recent weeks, providers in the non-profit sector have been very active. They have spoke about it, including in the press, saying that the publication of results was punitive. Those providers, they talk a lot about their staff demotivation and the loss of attractiveness when there is a C or a D rating. For my part, it is a personal view, but I regret that the interests of those receiving support are absent from those statements, because quality and transparency are owed above all to the people that are concerned, that are accompanied. Nevertheless, to answer your question, Cassandra, we are currently working in 3 directions to improve providers' confidence. First, as I said, we accompany the evaluators, and we try to strengthen the evaluators' specifications to increase our requirements about their training. We are currently working on it with the stakeholders of the evaluators' bodies. and we will write it into the specifications. The second thing is that we are working with regulatory authorities to ensure that assessment results are used as a lever for improvement and not as a sanction. And the third direction, the most concrete one, is the work with the Ministry of Social Affairs at this time to put into law the possibility of being reassessed during the 5-year cycle for the institutions that have received a D grade.
Thank you so much. That sounds very convincing, Ben. It does sound like a sort of lever then to have providers already start thinking about how they can improve should they have a poor score, and then already reapply for a reassessment. That sounds like an interesting approach. Now, I'm seeing so many hands going up, so I see a lot of people have questions. I'll go to one question in the chat, and then we'll go to some hands. Camille, do you want to ask your question out loud, or shall I read it?
I can do. Yeah, thanks, Cassandra. Hi, Angelique. Yeah, really interesting presentation, and thank you so much for doing it. I have lots of questions because I'm currently doing some work on this topic. But essentially, I mean, you've answered some of the questions already, but I wondered if you could just talk to us again about exactly the process of how the evaluating organizations, they're independent, is that right? And so they get a special accreditation from the accreditation body. And the reason I'm interested in this, to do a lot of work in the UK, is that the regulator in the UK, so first of all, struggles, I think, to have enough capacity to evaluate all of the social care providers. And so the organization is too overwhelmed, I think, to kind of really meaningfully reevaluate providers when they have poor quality ratings. And so you said that they are evaluated in a cycle of 5 years, but I suppose if a provider continually fails to, or stays, for example, in a D criteria, what happens? Are they removed from the market? Are there levers to be able to do that if the kind of improvement measures haven't been successful?
If the institutions, your question is about what happens to institutions if they have a D and they don't succeed to improve the quality. Yes, there are not if they don't succeed to improve quality, there are not some consequences. They are not removed from the market. What we try to explain is that with our assessment system, we want to put them on a trajectory to improve their quality. But it is not the same thing than the inspection and control. It is a separate thing. It is a different thing. So if they don't try to improve, if they don't reach to improve their quality, it is a challenge they have to address with their regulatory authority. They must ask for some ways to reorganize themselves, to address the questions with their staff, but it's not. It doesn't lead to some hard consequence.
Okay, thank you. That's very helpful.
Thank you. So I'll shift to hands now. I see Jose Luis has been very patient.
Thank you very much, Cassandra. And thank you very much, Angelique, for a really interesting presentation. I'm Jose Luis, I'm the director of CPEC at the LSC. I've got two related questions. One is, you've mentioned 5 years as the period of the cycle of inspection or assessment. 5 years is quite a long period. Lots of things can happen in a provider in between those 5 years. And I guess the reason for the 5 years is the resources for inspection. As always, we are limited in terms of how much we can do. But I wonder whether that is problematic, and whether there are ways in which that can be changed. You have talked about providers coming forward and saying, I want to be reassessed, but I wonder whether other triggers lead to more frequent inspections. But also, it's quite a complicated system. You've got about 130 indicators that you're looking at. I wonder whether you've considered reducing the number of indicators to make it more lightweight process, but to allow for a more frequent review. And linked to that, I wanted to ask you, how did you go about choosing the indicators that you chose? Quite a few of them are about minimum standards, I think, and rather than sort of final outcomes. Did you think about using quality of life indicators? Something that measures directly the well-being of individuals receiving those services. Thank you.
Thank you. Yes, you're right. 5 years is a long period, and that's the reason why many providers ask for a reassessment. We, in the HIS, we are in favor of this reassessment. It causes one problem. It's the financing of the assessment, because it is the institution that have to finance their assessment. So they tell that it is too expensive. So adding a reassessment during the 5 years cycle, it would maybe cause a financing problem. But what we can tell now, because this possibility of reassessment doesn't exist for now, is that they have to draw a plan, an improvement, a quality improvement plan. So we ask them to communicate more about this plan, to show what they are working on to improve quality. That's for the first part of your question. The number of indicators, yes, you're right. 157, it is a lot of indicators. This framework is very dense. It's a huge work for the staff also. In our thoughts about the next framework, we will try to reduce the number. It is something that we are thinking about now. I would like to reach less than 100 indicator. At least this step, I think it will be appreciated by the team. And how we have chosen the indicator, it is extracted from both the laws, the French laws. There are, for instance, some tools in the laws that the services have to implement in their institutions. So that was one origin for the indicators. The second one is an indicators driven from the professional guidelines of the HIS. We have produced some guidelines in the past about how to drive a self-assessment. It was before 2019. We have taken those works into account. And for the quality of life indicators, there is not a central quality of life indicators framework in France. It is not developed yet. It has not been developed yet, but it is a new mission that HAS would like to receive, because we have developed a program on how to take into account the public, the person expectations and needs, and we would like to develop this program to achieve quality of life indicators.
Jose Luis, I don't know if you want to respond. I know the UK does have, has done quite some work in the area of quality of life outcomes for people using long-term care services. I don't know, did you want to respond?
Yeah, I mean, I'm a great believer in quality of life indicators, and in the UK, as you say, we're using them. They are being used now in more countries. They present their own challenges in terms of the interpretation, in terms of how you move from those indicators to change. But I think ultimately that's what we're trying to improve, and therefore we should try to measure it. So it's great to hear that in France you're thinking about, developing those. I hope that what you end up is something that then is comparable with other countries, so that we can learn from each country rather than each country developing their own indicator, which would be a bit of a shame, I think.
Yes, I think it would be great to talk more about it, because we are just beginning on those topics. So if we can have benefits from your experience, it would be really great.
Thank you. I'll shift back to the chat. I see Neve O'Malley had a question or a couple of questions. Did you want to ask them personally, Neve?
Hi there, how are you doing? I had a couple of questions. Yeah, I think one of them has already been covered, the frequency of the evaluations. The other one was just, I suppose, in terms of, I have two actually now, I have another one, I was just going to write you another one. In terms of the providers, if they are failing, we'll say the imperative criteria on a regular basis, what happens? What action is taken, and which agency takes that action? Is it the regulator who will subsequently come in and take action? And then finally, I'm just wondering, in terms of the regulators themselves, are they carrying out any evaluations? So, for example, in Ireland, we have a regulator here, they're independent, but they will carry out the inspections and the evaluations themselves. So I'm interested in this sort of distinction between the evaluators and the regulator. Thank you.
Yes, thank you for your question. If the providers fail on important criteria, especially imperative criteria, what happens, it's the regulatory service that can do an inspection on that basis.
Okay.
The evaluation report can be used by authority to choose in which service they want to go to do some inspections. The HIS doesn't have the inspection mission.
Okay, thank you. That's really helpful. Thank you very much.
Thank you. Okay, going back to the hands up, Michelle.
Yes, okay, thank you very much for your invitation. I am French, so it could be easier to speak with Angelina, thank you for anyway for your big effort in English, because it's rather difficult when you don't use to speak English all the time. So I'm belonging to H platform. I am a chair of dignity and long-term care in Belgium, in Brussels, in fact. But I am in charge in France, in Burgundy, because I'm living in Burgundy, and we have to provide some report each year about what you are taking, the HAS are taking and looking after what's happened in the hospital and on the clinics. But I heard from health agency in Burgundy, we should work on the housing and home housing, because it's very different and it's very important. It's very difficult to make an evaluation if you go in a private house to understand what's happened and what the quality is done to the elderly person. That's why I was wondering how you manage to make this kind of evaluation, because when we are working and providing reports that you're receiving each year in the HAS for the hospital, for the clinic, we ask the hospital and the teams, the doctor, and etc. But on a private situation, in a private institution, I think is very, very difficult to do something, this kind of evaluation, you know. That's why the health agency in Burgundy, but I think is a decision probably on the Ministry of Health, but you know what's happened in France at the moment, everything is blocked, as you know. It's not a joke, but it's a real point, and maybe it could be very interesting that the CRSA, you know what is a CRSA? It's Council Regional of Santé and Autonomy. It could be very interesting, very hard job for us, but could be we have the power and the facility to help you in your report. That's just the intervention that I wanted to do with you. But I would like, if you agree, was my good proposition to work with you in French. In fact, it should be easier, you know, if you want to. I will send you my email, and maybe we could have a contact to work with together to provide and to be better that we could do. Well, I'm very pleased to be in this webinar, but I think we have to continue to work in French in France about that. Thank you very much, Angelique.
Thank you very much, Michel. I completely agree to work with you and to have some contacts. C'est quand vous voulez, Michel.
Because I have been, I work with the HAS long time to provide something about user in the hospital long time, well, not long time ago, maybe 2 years ago. So I would like, I'm speaking English because we are with a lot of English speaker, but I would like really to do something with you, if you agree. Of course, it's a very good proposition.
Okay.
Thank you. Anyway.
Thank you. Thank you. In fact, working with representatives and families of individuals is very important for the HRS and for promoting quality. I know it's not easy, as you said, Michel. It is not easy to convince the managers of those institutions, and especially in the private sector, to communicate about what they are doing on the quality management towards the family and the representatives. It's a really hard work to do, and it's a good point if we can do
if
that
we can
together.
work together, because I know, because we provide every year report from the hospital, and it wasn't so easy. It's better than better each year, but I think this kind of work on the housing and is different. But I think we have to work in France, because when I have some meeting in Edge platform last week, I was in Brussels, and can compare what the different country can do for the housing. And I think in France, we are not good at all. Is my conclusion.
Okay.
Thank you, Michelle, very much for your questions and intervention. I'm mindful we have 20 minutes and we still have a lot of questions. I skipped back to the chat quickly. Bellis, you also had a question. Did you want to ask it personally?
Yes, please. Yeah, we already mentioned the large amount of criteria. And I think it's really interesting that you separate between the imperative and the expected criteria. But I was interested in to hear a little bit more about how the visits are structured and how the criteria are assessed by the evaluators. Can you tell a little bit more about that?
Oh, yes. About the assessment visit. They have to, the first step is that, I don't know if it was very clear, it is the service itself that choose its evaluator's body on a list where the accredited evaluator's body are. So they have to choose the evaluator's agency. And then the first thing is that each service have to propose to the assessors a list of people, accompanied people, that can be interviewed by the assessors. So the assessors have received that list of people 1 week before the visit. And so they pick into those lists the people they have to interview. There is a minimum of people to be met depending on the size of the institution. So it is 3 people to be met for the small institutions, and it goes up to 8 people to be interviewed. So the assessment visit is at least led in 2 days, but it can go up to 3, 4, 5 days, but it has a cost consequence, of course, if they add some days. The first thing to the visit is a briefing meeting between assessors and the staff of the institution. So they have a briefing meeting, then they visit the location, and then they meet with the accompanied people. After that, they meet with the staff that take care of the people they have interviewed, to have a cross reflection. They have a scale, and they have to put a grade on every assessment elements between 1 and 4. On the second day, they will meet first the professional and then the management system to see if what the managers tell it fits with what the staff tell also. And then after the visit, the assessors have 1 month to produce the report. Then the social service has 1 month to put on some observations. And then the assessors close the report. And 3 months after the report has been finished, it is published on the HRS website.
Okay. And are residents and families also involved, or?
Oh, that's a good question. Residents, they are met, only residents. They can be accompanied by a family member if they wish, but we insist on the fact that it is the words of the resident itself that is taken into account.
Yeah. Okay. Thanks.
Thank you very much. So I'll go back to the hands. Birgit, thank you very much for your patience until now. Please.
Yeah, thank you very much, Anjali, for sharing all this information. I have a question and then a comment. For countries, the question is, for countries which do not have a nationwide quality framework for long-term care services, it's often very difficult to establish such a framework, right? And I was wondering what we can learn from your experiences dating back 2019 and before. So what were the reasons at that time for setting up these working groups to develop these quality frameworks for social services? Was this just a demographic pressure, or were there other developments or specific windows of opportunity to get this going?
What has happened is that there was some quality assessment well before, since 2002, but we hadn't any national framework. So every sector made its own framework. So there was not a common foundation, and the general inspector of the government had made in 2017. They have wrote a report on the difficulties of this quality assessment without any national tools. Of course, there was some kind of pressure by the people themselves and their families. So this is why the HRS, because HRS had the experience of developing a framework for the hospitals for more than 20 years ago. So it is the reason why the government asks the HRS to do the same work, that is to build a national framework for the social services. So we, even if there wasn't a national framework, as I told earlier, we had some some professional guidelines, and that was the beginning of our work to build that framework. But we did really a co-construction exercise with the associations, with the peoples, and with some experts.
comment is we've just closed a project that integrated quality of life indicators into the national quality certificate in Austria for care homes. So if you're interested in how this is done, you can approach me or Jose Luis, because we developed this with our colleagues from the University of Kent. So there is something there, and this will be used in Austria. So it has been already used, and this is in place. So if you're interested in integrating the quality of life perspective, there's something there that perhaps can also be used.
Yeah.
Yeah. Good.
Okay.
Great. Thank you.
Thank you. Thank you.
Again, I thought you were going to reflect on the mess of quality across provinces in Austria and how difficult it is to try to integrate these, but yeah. Okay, we have last 10 minutes. Susanna, thank you so much for your patience, please.
Thank you very much for this excellent presentation. I would like to ask whether in your new French evaluation system, you also work with systematic reviews of all clinical deterioration that lead to hospitalization, emergency transport, or death. Because in Slovakia, we have several years in our facilities of experience using a structured checklist and more recently also with AI-supported retrospective analysis for every single deterioration case. It has significantly improved our processes and early warning practices. In such a systematic deterioration review process considered or planned in France as part of quality and risk management, it's one point, one question. And the second one, tell you my colleague, Alena.
Yes, hello. So, of all, thank you very much for the presentation. It was great to hear about your experiences. We are very surprised that the quality can grow also with such institutions and such a point of views, because in Slovakia we have a problem that the care providers have a problem to keep the quality in daily life. And it's also because it's more or less a punishment system. So if you are not very good in all these indicators, then you can be punished. And this is something what we would like to change, because this problem with the quality in the social care homes in Slovakia is really huge. And we are sure that it's not a problem only in Slovakia, but also in other countries within the Europe. So we actually created something like a care deal, because we are sure that something like a green deal it's done for the people. The care deal is very important thing which should be do like a project within the Europe, because it's necessary to have a very, very strong voice in that topic, because only so we can change this. So last week we were during the CCDC Social Services Plenary in Brussels. One message became very clear, and it was quality in long-term care cannot arise without a stable and well-supported workforce. It's very, very important. So we are sure that also with this our project, we have done a concentration on some 4 topics, like employees, then the digitalization, because this is also a huge problem in many providers, then the stronger training for evaluators and providers, and partnership with countries that already have some very good practice, and we could really share it. So we are very sure that we should focus on these 4 topics, and maybe we could send you this care deal, this proposal for a project will be created in Slovakia. We would like to ask you if you could maybe share it as a material, and maybe if we would find some partner for that, or if you know about somebody who can help us with this project, we are sure it could really help not only us but also other countries. And we would like to make it like a project with 5 countries, for example, with where we could compare the best practices, how the quality is measured, how the people staff is stabilized, which everything what is done in that social care sector, and we would like to ask you if you could help us with that. Thank you very much.
Thank you.
Thank you very much to you. Yes, we are really convinced that if we want to convince teams that quality is worth investing in, we need to spread a positive vision and not a tool for punishment. So we have now a great experience in HRS, and we have seen that it is the good way to handle it. And if you want to create some international exchange about it, I would be really thrilled about it. Don't hesitate. It will be really nice, and I'm sure we will learn a lot from you also. So it's okay for me. And for the other question about systematic reviews on health risk, yes, we're doing it, especially in the health department. So I'm not the better person to talk to you about it, but we have developed those systematic reviews, especially to manage risk in healthcare. Yeah.
Thank you very much.
Thank you.
Thank you. So I'm aware we're coming to the end of the webinar. We had one more hand up. Hank, could I ask you if you could keep it somewhat brief so we can still close out?
Yes, I can. Well, thank you very much for the excellent presentation, Angelique, and also the input in this webinar for next the special interest group meetings. Is interesting to hear. I was sort of struck by the fact that you have consulted, Angelique, the general audience, and that you had 9,000 responses on this draft framework. What type of responses did you get, and what type of people were responding? Because that's a very elegant and unique approach for as far as I know.
Oh, yes. Hello, Hank. Yes, it was really a great success, this public consultation. I think that the HRS staff didn't expect so many answers. It was many representatives of people, association, and many professionals in institutions that answered. But unfortunately, I was not in the HAS at that time, so I haven't had the time yet to go checking those material, but I can see if we have a synthesis about those returns and tell you later about it.
Thank you very much for the concise response as well, Angelique. So I know there were many...
Excuse me, can we have the email of Angelique, please?
Yes, sir. I put it in the chat.
All right, thank you.
And I just wanted to say, I recognize there were quite some comments in the chat over the last 20, 30 minutes. We'll make sure that Angelique does see them and does have them, as I can't go through all of them now. But I would just say thank you so much to everyone for participating today in the webinar. Thank you, Angelique, as well, for taking the time to present and to have this discussion. I think it's been fantastic. I think there's a lot we can learn from the French example, and there's a lot we can share across countries, across organizations in terms of challenges. So this has been wonderful. I'm not sure, who do I pass it off to now? Shall I pass it off to you, Adelina?
I think, yes, I'll wrap up to say thank you so much to the interest group for organizing the event, for Angelique for such a really wonderful way of bringing to life how it actually happens in practice in France and all the considerations and reflections. And thanks for all the engagement from all of you. We're very keen to support collaboration, so please do get in touch, and looking forward to seeing you at our next webinar. Have a good rest of your day. Thank you all.
Thank you.